Once again, this is the CDH Dad and
the CDH Warrior.
And welcome back to Mondays on Mondays. For those of you that are not familiar, what we do is once a week we do a program on Monday. Our last name happens to be Monday, so it's Mondays on Mondays. The topic that we generally cover is dealing with families that have to deal with the situation of having children with medical special needs. The reason that we do this is that my wife and I had our first child, my son, who was CDH, congenital diaphragmatic hernia. This was a condition that we did not know about in utero. We were not aware of it until his birth. And then we had to go through transports to different hospitals, medical treatment, surgery, repair surgery, other surgeries, a lot of treatments, therapies, etc. And went through several years of that. Yeah. And then we had my daughter 2 years later. We checked, we made sure everything was fine. We did not see any issues with her health at birth. And then we were surprised at about 1.5 years when she developed a condition called aplastic anemia. Now, from the statistics, congenital diaphragmatic hernia occurs about 1 in 2,500. Yeah. So it's fairly common, but it's unknown because it's not really mentioned that much. Yeah. It's not really discussed that much.
For explanation, I think it's actually as common or more common than spina bifida.
Right, it's in that same classification with a lot of other childhood defects, birth defects, but it's just not mentioned and not known.
Yeah. And
I think part of that was a fact of that up until just recently, the survival rate was about 30, maybe 50% chance if you were lucky.
Yeah.
So it was not discussed on a regular basis. In my daughter's case, with aplastic anemia, in children it occurs about 2 per 1 million children. So it's not at birth, it's not a birth defect, it is a childhood effect, idiopathic aplastic anemia. And we'll kind of discuss a little bit about aplastic anemia and the understanding of what it is. But when it only happens, one in every 500,000 children, yeah. It's rare that you deal with that.
And then you add, in my sister's case, the odds were 1 in 2.5 million because of the fact that she was under the age of 2.
Right. I mean, it's extremely uncommon. So part of our discussion as we get a little bit further is going to be into discussing the illnesses and truly understanding what those illnesses are, because we do have problems with congenital diaphragmatic hernia. People associate, oh, it's a hernia. No, with CDH, it is a hole in the diaphragm, and the organs from the abdomen go up into the chest and impact the growth and development of the lungs and the heart. That's part of the reason that the survival rate was so low until just recently, is it wasn't detected that often in utero, and then even after it was detected at birth, the treatment protocols were not really in place, and they really didn't come into place until my son's time.
Yeah.
And he was fortunate to be with the doctors who specialized in CDH and was working on a new protocol, and I think you were the 25th patient.
Yeah.
In his protocol and in his testing to see how viable that protocol would be. So now that doctor has about a 90 to 95% success rate.
And I'm going to point this out. That at the time experimental protocol is now considered the gold standard for CDH care.
Right. So these are the top things that we try to discuss in our weekly topics. We will again give you the disclaimer that neither of us are medical professionals. We don't have medical degrees. We're not doctors, nurses. We're not therapists. We're not sociologists, psychologists, anything along those lines. But we do have a wealth of knowledge just based on the fact that we have had to experience and go through these things.
Yeah.
And if you are a parent that has a child that has these special medical needs, you realize very quickly that you become an expert on a lot of medical topics. And since my children are quite diverse in the medical backgrounds, my wife and I had to learn quite a bit of medical knowledge. So that just gives us the basics on this. But thank you once again for joining us for Mondays on Mondays.
With that, let's roll the title.
And welcome back, everyone, to Mondays on Mondays. At some point in time, you should see an email address on the screen. So if you have any questions or comments, you're more than welcome to contact us and let us know what you see. As I've said in the past, we tend to follow a lot of things on social media between your activities with the CDH nonprofit group. And then we also, I follow some pages with aplastic anemia and with graft versus host disease, which are two things that we had to deal with. So that just kind of gives you a general idea of the concept. Now, part of what I wanted to bring up in this discussion is something I've seen on some of the social media sites. And, you know, these are sites and people that we try and be able to communicate and provide information and share information, because these are unique illnesses that we're dealing with. And, you know, even the doctors have difficulty knowing a lot, because it's not that often that they may see a CDH child. It's, you know, it's not that common for an obstetrician to have a child that was born with congenital diaphragmatic hernia, and yet that's one in 2,500.
Yeah.
If you have one with aplastic anemia, in that case, it's astronomical. You're lucky to have anyone in the same state or same region.
Heck, forget that, same country.
Yeah, that was something I saw. Go ahead.
In the United States, I believe there are only 4 hospitals in the entire country that are actually set up to deal with aplastic anemia. 4. To put that in perspective, there are roughly 40-ish hospitals. I know doesn't seem like it's that much more, but 40-ish hospitals that are set up to treat CDH.
Right. And these become highly specialized, because with CDH, in order to truly be able to treat CDH and follow a true protocol on this, you need to have a hospital that has the facilities, that has an ECMO unit, extracorporeal membrane oxygenation. Basically, it's a heart-lung bypass, but it's on a size for a child.
Yeah.
And not only do you have to have a unit to do that, you have to have 2, because you have to have a backup available at all times. And then you have to have a respiratory therapy group that are trained in how to do this, because you will have to have a respiratory therapist or a therapist who is on site 24 hours a day while your child is on ECMO, because all it takes is one little blip and you've lost your child.
Yeah.
So it's highly specialized in that case. With aplastic anemia, it ties in with a lot of hematology oncology groups. So you go to the specialty of you've got to have hematology, oncology, then you have to have someone that is pediatric hematology oncology, which is a smaller group of people.
Yeah.
If you're fortunate, you will go through a transplant,
Yeah.
which is basically a bone marrow transplant or a stem cell transplant. And in that case, you've got to have a hospital that has the capabilities to handle those things and handle a transplant unit, which means you've got to have isolation. You've got to go through total body irradiation, chemotherapy, all of the things you would do in a lot of the cancer treatments.
Yeah.
And as I said, part of this is where I wanted to bring up, because on the sites I have seen some cases. It's not quite as common now, but every so often you'll have someone that, oh, my child has a hernia, what can you tell me about this? And it's like, you know, it's the wrong group, because if your child has an abdominal hernia, that's
a whole different.
That is a concern for your child, but the capabilities and the medical knowledge required are totally different than it is for an internal diaphragmatic hernia, where basically the diaphragm separates the chest from the abdominal cavity. It's what is used to be able to breathe.
Yeah.
So these children are...
And in that case, in the case of CDH, a lot of times it's either that there's a large hole or the diaphragm is completely missing. And yes, I've seen both cases.
Right.
Where it's just completely not there. And I think that's where people misunderstand.
That
it's outright life-threatening.
Yeah. They have difficulty with that, but one that I saw recently was someone that got a blood test back and, well, my child has these results. My child is anemic. You know, what can you tell me about that? And anemia is related to
iron deficiency.
Iron deficiency in the blood. It happens in a lot of cases. People will, you know, their diet or illness will affect their body's ability to keep an adequate amount of iron to be able to keep their oxygen levels high in their body.
My mother
and
was
in the blood.
Anemic.
Yeah, and it's quite often in women, particularly during the menstrual period, that they will lose blood. They will lose red blood cells. Mm-hmm. Their body cannot recover quickly to replace that iron and the blood cells, and they become anemic. And it causes fatigue. It causes a lot of issues. With aplastic anemia, basically the condition is your bone marrow, which produces your red blood cells, produces your platelets, produces your white blood cells, will work at a reduced rate, or, as in my daughter's case, totally shut down.
That's for say.
And you're not able to produce any blood cells, or not enough to be adequate for what's needed.
Most commonly, when you have aplastic anemia, it is actually considered bone marrow failure, as opposed to like where you typically think of people that are anemic, where they're iron deficient.
Right.
And that's a rather large difference between the two.
Yeah, and it's a very rapid learning curve that comes into play. When my daughter was diagnosed, identified that she had a blood disorder, I spoke with the doctor, and the doctor happened to be a neighbor and someone we knew, and she came to us and said, okay, I've determined that your daughter has either aplastic anemia or leukemia. And my response was, well, I've heard about leukemia. That's fairly well known. I don't know about aplastic anemia. I'm familiar with anemia, but not aplastic anemia. And her response is, pray for leukemia. Because aplastic anemia is in a condition that the clock starts as soon as you're diagnosed. Because at that point, with my daughter, she had large bruises, and we couldn't determine why she had the bruising. She had had an illness just a couple of weeks prior to this, which was a typical childhood ear infection, the first that she'd really had in her life. Had gone to the doctor, gotten some antibiotics, came home, and then the following week we noticed the bruising. Went back to the doctor. The doctor pulled blood samples and sent those off for analysis, but we noticed that her condition was declining very rapidly, and this on a Saturday morning. We still didn't have the blood results because it takes a while to get those results back.
Whenever you're dealing with blood tests, it's generally 48 to 72 hours
Right.
for a blood culture.
Right. But in this case, our neighbor happened to be a doctor, a pediatrician, and also director for the health department, and was walking through the neighborhood doing her regular fitness walk. And my wife saw her, started asking her questions. She came in, did a preliminary examination of my daughter, and told us that she would be at the hospital the next day and to bring her in. So we went in with her to the hospital to have this diagnosed. And it took a few hours of doing the blood test, but once she got that, she was able to quickly determine that there was a problem with her blood system and send us to a larger facility which had the capabilities to truly diagnose and treat this, whatever it was. We ended up going back to the same hospital that my son had ended up in, which was 4 hours away, but we were familiar with the hospital and familiar with the facility and the people. But as I said, in that case, there's a stopwatch basically in your life that starts clicking.
Mm-hmm.
Because once she was diagnosed, you have to start looking at what are the capabilities that you can do. This is not a typical anemia. The bone marrow doesn't produce blood cells. So she had to have transfusions. Her platelets were so low that if we had not gotten her to the hospital that night, she might have possibly spontaneously bled to death, because she did not have adequate platelets just to take care of what would be an occasional seepage of blood within the body.
Yeah.
So, it's a quick case. Now, we rapidly found that if you have a child that has aplastic anemia, you need to look very quickly at the potential to do a bone marrow transplant or a stem cell transplant. The reason for that being is once you get past about 25 transfusions, the blood system has difficulty accepting a replacement blood system.
And
Your body will, it just won't work adequately because you keep mixing new blood cells in with the existing blood cells.
it gets to a point where it has a hard time recognizing itself.
Right.
And it will literally start attacking the bloodstream and organs, which
Right.
is where you have the issue with GVHD, graft
Right.
versus host disease.
Right. And it's virtually impossible to have a single donor blood supply
Yeah.
to be able to do this. In the case of my daughter, was one that she had to have platelets about every 8 days, and she had to have red blood cells about every 2 to 2.5 weeks. So every 14 to 18 days, she had to have,
Yeah.
a transfusion for the red bloods. Every week, she was having it for the platelets. So when you start that clock ticking and saying you've got to have, you can't go past 25 of these. That means that you've got to very rapidly make decisions, do analysis, and find out what is the potential and what's the capability of what's out there.
In the case of 25 transfusions, you can go through, to put perspective, is timing between, if you're counting platelets plus whole blood, you can actually override that in a month and a half.
It's longer than that, because it's basically platelets is about 4 a month, red blood cells 2 a month. So you're doing about 6 a month.
6 a
So
month,
you've
okay.
got 3 to 4 months to make this decision. During that time period, you have got to evaluate, do you have a suitable match to be able to do the bone marrow transplant, the stem cell transplant? And genetically, it is very rare, unless you have an identical twin, that you have a genetic match within your family. The parents are going to be basically a 50-50.
A
So
sibling is going to be, unless they're an identical twin, they'll be, what, 75?
no, they're about a
Or they're
25%
25.
potential, because they're about a quarter. So it dilutes down as you get in. So it's difficult to find a close match. So we were fortunate that we were able within a few weeks to find 2 potentials that were a 5 out of 6 HLA match. And it was not really known that well at that point in time. It's better known now. But we made the choice to use a female, a young girl who the parents had donated her umbilical cord to a donor center. And we were able to use the stem cells from that and have a match, because not only is it HLA match that comes into play, but it's also when you've got an infant, then you've got the gender differences that come into play, and how does that impact the later life. And since this is such a rare condition, there's not a lot of data to be able to pull and look at those things. So a lot of this are things that you have to get up to speed very quickly. So I'm not trying to downplay some of the illnesses that come up. I mean, a hernia can be a truly devastating and can be a life-threatening issue. Anemia can be a devastating and potentially life-threatening issue. But in the case of, when you're dealing with children that have some of these very severe illnesses, it's difficult to relate the fact that with a CDH or an aplastic anemia, as soon as you know about that child's condition, there is a stopwatch that starts.
Yep.
And there is a whole protocol that has to go into place. And as a parent, you don't have the knowledge and background and capabilities to fully understand all of those things. It takes some time to get to that. And you also, once you get into a medical setting, you find that sometimes it's very difficult to find doctors and medical staff that have that experience, because these are such rare conditions that you need to look at what are the capabilities within your areas and neighborhood. With CDH now, it's more prevalent that it is diagnosed in utero, and you can see that. With aplastic anemia, it's really just a shot in the dark to have the capability to find out what's going on. And those are the type of things that make it very difficult to be able to find a medical staff that can quickly come up to speed and understand. We were fortunate that we had a doctor that, one of our doctors had been in England and was familiar with the protocol there, that when my daughter had a fungal infection related to the fact that she'd had basically a devastated immune system, we had to annihilate the existing immune system in order for her to be able to take the transplant. She ended up with a fungal infection. He was familiar with a treatment method that could at least help us sustain her immune system for a short period of time until the engraftment of the stem cells took place. So there's a lot of medical terms and a lot of things that you have to come up with quickly, and I know it's very difficult sometimes to get to that point. But we've spent almost 3 decades going through and having to live through these things. So we're familiar with a lot of this stuff. And part of what we try and do with these discussions is try and, you know, enlighten and indoctrinate people into what are the situations and conditions out there, what are the medical capabilities that we're aware of, what are some of the therapy and the treatment and the other things that need to come into play and you need to think about from just a normal parent standpoint, and discuss those within this open forum. So that's the reason we do this. So I think we've pretty much completed our discussion for today. So thank you all once again for joining us, and have a great week.
Have a great day. We'll see you next time.